this time we have again with a very meaningful and relevant topic, GIPSA PPN facts and myth. And we are lucky to get Dr. Giridhar Gyani as our moderator. I'm sure that none of you need any introduction about Dr. Giridhar Gyani. But, as part of this official formula, I'll give a very short briefing about Gyaniji. The name Giridhar Gyani is, I think, synonymous with quality, because in his blood, in his life, in his thoughts, dreams, quality, that's the watchword. 9 years, sir was the Secretary General of Quality Council of India, NABH, CAHO, AHPI, all have great stories to tell about Gyaniji. Currently, sir is the Secretary General of AHPI and patron of CAHO. Gyaniji, welcome to moderate the session.
Thank you very much, Father Johnson. It is a privilege for me to be in the family of CAHO, and I'm grateful to Father Johnson for assigning me the role of moderator for this very important session. Discuss the very complex issues on the subject. But we have three very experienced people on the panel. And let me start by introducing very briefly in few lines only our friend Mr. Srinivasan, who is currently the director of National Insurance Academy. He has vast experience, when I say 39 years of experience in the insurance sector, that itself will explain what kind of person is going to be, speaking on the subject. He was CMD of the New India Assurance for 6 years and has held the chairmanship of General Insurance Council and General Public Sector Association, what is we call GIPSA. So I think he is very, very relevant person to speak today on the subject. Our next panelist is the Joy Chakravarti, another, stalwart in our healthcare industry. He has 21 years of experience in the healthcare, comes with the advanced executive education from the Harvard, and is currently on the member of the Harvard Business Review Advisory Council. Joy is a person, I think all industry, name the bodies, CII, CAHO, AHPI. He has been playing very, very important role to represent industry in with the government and with the other stakeholders. And then we have got the third panelist, John Vincent, which comes with a very specialized, education, I will say, because he's a chartered accountant and is a chief financial officer at Rajagiri Hospital. So he has 14 years of experience in the healthcare industry with a core competency in strategic planning, accounts, budgeting, taxation, audits, and risk management. So again, a very, very relevant person with a domain knowledge on the subject. Let me open with a few remarks. One is that, healthcare industry today, we have been saying this word, that the healthcare industry is at the crossroad. But today, actually, it is on the crossroad. I will just give a little background, because I keep saying in my talks that healthcare, unfortunately, was never on the political agenda till recent past. But 2017, we got a new healthcare policy, health policy, I will say. 2018, suddenly it came, from the, I'll sometimes call it from the blue, it came Ayushman Bharat, providing, the 40% of the population of the country with the, insurance of 5 lakhs rupees per family. Many people keep saying that the government launched this scheme without much of the preparation. Maybe partly it is true. But sometimes, when you launch something, on the way, you will overcome the difficulties which keep coming. But it is a game changer scheme for our country, but it will take few more years to really mature and make the impact. You see, if I go back to 2014, we used to say that only 16% of population is covered under insurance. Then few years later, we said 26% insurance is covered, rest are paying out of the pocket. And when in 2018, this Ayushman Bharat came, and then of course, I remember the member Niti Aayog made a tall claim that today we are covering 60% of the population through Ayushman Bharat, CGHS, ECHS, ESI, and the private insurance company. And he also said the target is to cover 70% population under government insurance scheme. Virtually, I mean, government is planning to have universal health coverage, which means, you know, the bulk of the population should be provided with the healthcare at the cost which it can afford. Because I always use this word, it is not free. Universal health coverage means the providing the healthcare at the cost which can afford. That means some population free, some at the co-payment and things like that. So if 70% of the population is going to be covered under insurance, if not now, maybe next 3 years, it is a very good sign for the industry. That means there should be huge investment coming in the healthcare industry. But on the ground, I also want to remind people, you know, and very briefly, that in 2018, the Prime Minister said that he will like to see 3,000 new hospitals in the tier 3 towns. That was the announcement he made in the Vigyan Bhavan. To best of my knowledge, I don't see any tertiary care hospital coming up in tier 3 towns in the recent past. But he is right in a way. If this is going to be the plan, and we have currently some 13 lakhs beds, and as per WHO requirement of 3.5 beds per 1,000 population, we need to double the number of beds now. So that means there's a huge scope in the healthcare segment, and to cover it up, naturally we need insurance. Without insurance, healthcare industry will not survive because population will not be able to afford. So this is a very tricky question. So what I will do, we can follow, of course, order, but I want to keep our chief speaker Srinivasan little late, because let me first bring the pain points, you know. And before the pain point, let me ask a national question, I'll say, from our experienced friend Joy Chakravarti. Do you think the health insurance will become the cost effective for the general public? This is a kind of philosophical question. That do you think health insurance will become the cost effective for the general public? I want your views on this.
So thank you, Dr. Gyani, for allowing me to set the context for the discussion. And but before that, I'm thankful to Father Johnson and the entire CAHO fraternity for giving me this opportunity to be here in this webinar today. Now, the question is whether it is going to be cost effective. The health insurance is going to be cost effective for the Indian population. So, Dr. Gyani, I can tell you that we have learned a lot of things from you, and I am going to share some of these views of mine on individual basis in this program today. When you say cost and when you say effective, these two are very subjective. When you say it is cost effective for a person, because today, the insurance, when you say cost effective, you talk about the premium. The premiums are for the same insurance policy is going to remain same for all the geographies, for all the people. Now, what is cost effective for me may not be very cost effective for the other person, for a simple reason that in a metro city, in a tier 1 city, the kind of bills, the kind of medical expenses going to happen may not be the same in the other geography. So this cost effectiveness also backed by your purchasing capability and abilities. So what we try to look at, it that it should meet my expectations. I'll tell you some of the very, uh, pertinent issues what we come across. If I have a 10 lakhs coverage and I spend Y amount of money to get that, I get eligible to occupy a certain category of room, but I may not be able to afford that premium, so I buy something less. But my expectation versus reality versus my buying ability does not match. Nevertheless, we need to be little rational for the health insurance policies also, for a simple reason that today everybody's expectations are also very high. So when I buy an insurance, I try to see that what optimal utilization I can have of that policy. So I start going into in a mode to see how it can bring benefits. In certain cases I may do something which is not right also. And in that process, your claims ratios and all goes up significantly. And as a result of that, insurance companies are forced to increase the premium. If I compare the kind of premium in India versus in the Western world, I'm sure that probably our premiums are very, very less. But what we need to see again, what I get against that. But I think in this war of price of insurance premium, the way we are heading, probably it may not be very cost effective for people, because looking at the complete population of 1.3 billion, though the bottom of the pyramid is taken care of by Ayushman Bharat and some other scheme, but even if I look at the upper segment, the kind of scenario is today, it is going to, the cost of policies premiums are going to go up, and soon people may find it is beyond their ability to get one and cover themselves. And so my straight answer is going to be, it may not be very cost effective for Indian population.
Right.
Stop here.
Good, good. So I think we'll come back to this solution a little later. So again, a kind of policy question to my friend John Vincent. Do you think the kind of insurance coverage is increasing, that is starting from Ayushman Bharat, CGHS, ECHS, and now private insurance and GIPSA, everything to put together? Do you think this is going to incentivize investment into the healthcare sector? Do you see next 3 years, number of beds will be increasing, number of new investors will be coming? Do you see that scenario?
Thank you, sir, for the question. Thank you. Just to add to what you have said earlier, I think the good thing about insurance companies coming is actually doing a good help to the public. No doubt on that. The problem is actually when the cost or the hospital bills are being regulated by the Association of Public Sector Companies. That is going to throw up big challenges. Now, if you look at the hospital average margin for the healthcare industry, it's a single-digit number. Now, if you put more pressure on that hospital margins, I don't know, I'm apprehensive actually if more investors would be willing to make investments in the healthcare sector. It will be very challenging because end of the day, like you said, at least it will take 5 years, 6 years to become 3.5 beds for 10,000 people. So that if you're looking at that kind of numbers, we should be entertaining the investments to come into the country. Or if the investment has to come, they should have some return in for that. So if I think so, insurance is good, but at the same time, there should be the regulation by the public sector companies on the price capping should be avoided.
Okay. So these are the two, I think I was the, context setting questions only. Direct questions will come little later. So let me come back to now our good friend, Mr. Srinivasan. You see, I was given a report of CAG audit. Actually, it came on 5th August 2022, which actually says that there are 32 general insurance companies doing the healthcare business. and out of which 4 are in the public sector. What is GIPSA, which you have chaired at one point of time. And this CAG report says that it lacks the systems and procedures for internal auditing, which are not adequate. That was I will not go into other details of the, CAG report. The question now is that we need insurance. There's no doubt in that. Government insurance, private insurance, GIPSA is in between somewhere coming up. Our pointed question from the industry is that on what basis the GIPSA fixes up the prices of the procedure? That is a very, $100 million question, which people keep asking. How CGHS rates are fixed, how Ayushman Bharat rates are fixed, and how GIPSA rates are fixed. So I think GIPSA, being a professional body, I think I am expecting that you will come out with a very scientific, way of putting us that how the rates were fixed. And then we'll go into further discussion. Mr. Srinivasan.
Yeah. Thank you, Dr. Giridhar, for the question. First of all, I would like to thank CAHO and Father Johnson for inviting me to be part of this panel. First, let me start by, raising a basic question as far as India is concerned. India has not reached full coverage as far as health insurance is concerned. Whether 60% of the people are covered or 65% of the people are covered, it's still a matter of debate. But what it means is there's a large segment of the Indian population which still does not have health insurance. I think it's the responsibility of all the stakeholders to ensure that, everyone has some kind of health insurance, because we have seen that people really suffer when they have a medical problem, and, the kind of bills they have to pay really, affects their economic situation. So I think that's one thing, all of us need to do as a country. Second is, I don't really consider, health payers and health insurers as, as kind of opponents, fighting some kind of a battle. Together, we are serving the ultimate people of this country. So if I may say, the patients are our customers. So I think it's time that, the healthcare providers as well as insurers come together, find solutions so that, the customer is able to get quality healthcare, is able to be happy about, getting treatment. Because today, even in health insurance, people get claims, but people are still not happy. When we make some deductions, they are unhappy. They are unhappy with the hospitals. They are unhappy with the whole ecosystem. I think we need to change this. I think together we need to change that. So that's the first, point I just wanted to make. Now, coming to the health insurance space, I think I would also like to remove a misconception that it's only public sector players who are in the health insurance space. There are a lot of private sector players are also in the health insurance space. So the space is, widely distributed among the 4 public sector players, as well as the other, 25, 26 other general insurers and standalone health insurers in the country. Now, to give you a little bit of background to this preferred provider network, which I think is a very important topic being discussed, PPN. This was first done in the year 2010, because I was also actively involved at that point of time. One of the key objectives of coming out with the standardized rates for some of the procedures, we have not done it for all the procedures, is to really handle the major problem of healthcare in our country. Because if health insurance is not becoming affordable, as I think Mr. John or Mr. Joyce said, it's because healthcare cost is not getting affordable. Because health insurance is a function of healthcare cost. If the healthcare cost increases, health insurance premiums will go up, because the insurers are not going to do a business at a loss. Though at this point of time, I don't think any health insurer is making profits. Everyone is making losses for various reasons. I'm not getting into why they're making losses. So the health insurers will also lose motivation if they don't see some viability. Just as hospitals want to see some viability, the health insurers also would like to see some viability. So that was the context in which this preferred provider network was introduced way back in 2010, when 4 cities were first considered. Some 42 procedures were brought into this. Today, I think it is now around 10 cities and about 130 odd procedures have been brought into this. Your question, how is it done? I mean, I can assure you that it is done in a scientific basis. I mean, there could be difference of opinion between the hospitals and the insurance companies, but we use healthcare experts, we use doctors. We also talk to third-party administrators who have a lot of experience in this. we also talked to hospitals. So this is something, when it was put in place, it was discussed with hospitals. There were a lot of, difference of opinion, and we sorted it out. That's how this got settled down, and it's been now running for the last 12 years. So, it is not done just like that. Nobody sits in an office and prepares the rates. It's being done after a lot of discussions with the healthcare professionals. But I do agree that there is always scope for improvement. There is always scope for discussion. And, I think all of us will have to be viable institutions. We don't want hospitals to make losses. We also don't want insurers to make losses. So it has to be win-win for everyone. I think that's where I'm saying we need, constant communication, discussion. But, when the PPN was introduced in 2010, it made a huge, it became a big issue in the country. It also became a parliament question, and if some of you can recall. But ultimately, it brought the hospitals and the insurers together. I was also part of some of those discussions. Some of the major, healthcare providers and the insurers, we sat together and we all discussed what needs to be done so that healthcare improves in our country, and health insurance plays a much more important role. I think that needs to continue, but I can assure you it is done on a reasonably scientific basis.
Good. So, I will remind you, during the COVID phase, the many state governments, they came out with the, rates 10,000 rupees for the general bed, 15,000 rupees for the oxygen bed, and 18,000 for the ICU bed, the industry did represent, but that was the time, government wanted industry to be sensitive and, manage with this cost. But on top of it, what we found was the insurance companies also came forward to us that if you are managing with this cost from the government, why can't, even under our, clients also, we will also pay you the same amount. So we told them that this is a kind of cross subsidy. We are managing with the government on this rate, but we expect the insured patient to be covered under the agreement. But there was a lot of, up and down. And finally, I think we came to the conclusion that, okay, insurance company agreed. So sometimes, what happens, because government rates, let me tell you, I have been in government for 30 years, were fixed by, the lowest quotation kind of things, so they were never scientific. And in fact, to be very frank, no scientific study has been done by the government. So the GIPSA should never actually rely on that. What if government is paying this, we also will pay the same thing, because we still consider that the private insurance actually is going to provide us the subsidy kind of thing. So I think with that background, let me now go to Joy once again. The operating costs I just mentioned to you, 10,000, 15,000 and 18,000. And if we do a bit of costing, that activity-based costing, which has been done for the tertiary or quaternary care, the ICU bed cost will never cost you less than 25,000 or something like that in tier 1 town. I mean, this is a scientific study done with the help of AIMS and other association. So I want to ask Joy that, do you think hospitals will be able to cover this increasing operating cost with the standardized cost by the GIPSA? And how do you, bring the balance between the two?
A very good question, which touches probably all of our hearts, if it is not mind. That, you are very generous to say during COVID, the governments were giving 10,000, 15,000. In Maharashtra, for a general ward or non-ICU bed, we were restricted at 4,000, and for the ICU, it was 7,500, including the ventilator, including doctor's visit, including everything. Now, that was a different tough time, I agree. But I can tell you what we have got to know from HPI, especially from you, when there was a very, I'll not say very in-depth, but the study which was done where we have seen 12,500 to 13,000 rupees is the cost of running a general ward. The kind of cost we incur to pay the electricity bill per bed per day, if we take all this into consideration, then probably this 4,000, 5,000, 10,000 are nothing. Now, can we manage with this kind of standardized cost? The answer is straight away no. Today, I can tell you when that is COVID or whether dollar, rupees, the kind of exchange rates are going on, every day we have tremendous pressure on us to manage the cost. But if you go back to the payer, probably you will not be able to justify that. I'm giving a simple thing. Today morning, I was shown that paper, simple A4 size paper cost vendor is increasing by 18% because of multiple reasons. If I go into the medical consumables and all this, then these are also going up simply by citing two things. One is your dollar conversion rate, and second is your freight charges have gone up obnoxiously very high, which is leading to increase in all this cost. But if I try to manage within that given framework of so-called allotment by the insurance company, and I'm not going to talk only about GIPSA, but any insurance company, they are not in a position to listen, agree, accept, and acknowledge. When they don't acknowledge, it becomes a some sorts of what type of situation, that how do you manage? Some of us, we reach a situation, we say, we'll not entertain this insurance, we'll not do this, let the patient go out and go for a claim in their own like reimbursement. But that may not be a very healthy situation. If you really look at the scenario in the Western world, and I'll take the example of US, because always we quote the kind of population is covered under insurance there. It is the highest coverage they have in their country. But still, if you see hospitals, they operate with, like a hospital like John Hopkins, with 1.5% EBITDA. If you think about a hospital like Cleveland Clinic, they are not even more than 2% of EBITDA. The reasons are simple. The skyrocketing cost of healthcare, what Mr. Srinivasan has already mentioned in the initial remarks. Now, with this increasing trend, and the next component I want to bring, which is the manpower cost. In one hand, we want to get the best of the healthcare, but we are ready to pay the third world cost, which is not possible, which cannot balance for a long time. If you really need to get in Bombay city, a MBBS doctor will not come to you less than 75 to 80,000. You can't afford to have somebody like a qualified nurse who can come and work for you less than 25 to 30,000 rupees. And similarly for all cadre of staff. So I think with this increasing trend of expenses cost, which is going up every day, sticking to this standardized cost, sticking to this standardized kind of model is really not going to work. We need to have some sorts of understanding, some sorts of mutual, I think, acceptable norms to see how we really can put our hands together and work.
Thank you. But at the end of this seminar, I will like to have the way out, way forward. I think this discussion, what you are saying is absolutely true. This is the reality, ground reality, because you have been operating officer, chief operating officer for so many years now. But we have to find out the solution also. And for that, we'll come to Mr. Srinivasan and my other colleagues on the panel. But before that, Mr. John, let me ask you this simple question. If this is the scenario, for example, CGHS rates are unchanged since 2014. Obviously, inflation has gone, but still, and we are managing. And insurance company also cite the same thing, that if you are managing with the CGHS rates since 2014, why are you asking for the revision? So do you think, the first question which I asked you, do you think there will be an investment in the healthcare? Or do you think the existing industry also may collapse if this is allowed to continue for a long? You are a very qualified, experienced chartered accountant. I want to ask you this question, that do you think investment will come? Or maybe the existing industry also may partly collapse?
just to add to what Joy sir has said, he has touched upon the existing scenarios, what we are facing in the industry healthcare. And now, if you look at the GIPSA PPN agreement, it is for a period of 2 years, next 2 years or 3 years or longer period. Now, if we can't cover the cost for the next 6 months, how is that we are going to manage it for the next 2 years? So that is a very big challenge. Now regarding the investments, whether it will come or not depends on how we evolve the market now. If we are adamant and we are regulating the rates of restricting the fair competition, of course, there is hardly any investment you can expect in the next couple of years. So we will be back to square one. We'll be where we were another 3 years back. So it's actually a very challenging environment what we are going to face. With 60% of the insurance business is with GIPSA companies. Now, of course, the private players is going to follow up for the same rates as GIPSA PPN rates are there. There is no reason for the hospital to say no to the private players. So everything that, as when Dr. Srinivasan sir said that insurance is going to be a big benefit to the public, at the same time, the hospitals also have a concern that now bigger chunk is going to be under the price regulation. So who is going to make an investment seeing all these regulated market? It's a big challenge.
Okay. So now come back to Mr. Srinivasan. You see, recently I was given a feedback from one of the major hospitals in Bangalore that they had 24 crores outstanding on November 21. This is last year, thing from the GIPSA alone, I'm saying, So that means rates is one pain point. How do we fix it? But even the reimbursement, which is supposed to be within 30 days, actually is not happening. Actually, we have to find the reasons. Let me tell you, we met Honorable Minister, Health Minister on 18th May. Oh, sorry, no, 24th May only, person to person. And we highlighted this issue that CGHS, ECHS, insurance, GIPSA, all these issues we highlighted. I mean, I know in the weak moment, he said, I will like the rates to be, revised every year based on the wholesale index. We clapped, we were so happy that if this can really happen, this will solve the problem. We'll have to keep reminding him, sir, that you said this one. But before that, the rates have to be brought to one, minimum datum, that today what should be the rate. So again, I think you have to play an important role, GIPSA. Maybe that becomes the guiding factor for the government, So the issue now which I want to ask you is that how you think, because now ultimately we have to give answer to the people sitting here. And let me just add one more point. That, politically, government wants to say we will provide healthcare free to masses, but they do not have the resources. 1.3% of GDP still remains same. So capex they do not have. They should depend on the private sector, and they incentivize them to invest, provided they are able to reimburse at least the operational costs. And we have suggested that why don't you talk of the co-payment from certain segment of the population, which can afford little more. We can come up with the co-payment to the hospital over and above the cost which is fixed by insurance or fixed by the CGHS. So these are some of the points, which we have been thinking as a solution. Because just merely talking the, popular thing that we will provide free healthcare is no solution because government doesn't have the financial resources. So I think I want now from you, and then my other friends will join us to find what is the way forward under these circumstances.
Yeah. So let me, rephrase the question. The healthcare providers would like, whatever they bill should be paid by the insurers. Now, that is not going to happen. That doesn't happen anywhere in the world. I mean, the more developed the country is, the more regulated is the, the payouts from the payers to the hospitals. You take US, the insurance company will even say that for this treatment, you must take only one X-ray. You can't take even scans. So they even go to the extent of even influencing the method of treatment. I mean, India has not gone to that extent. So you will not be able to avoid packaging of rates in the Indian context. But what needs to be done is this packaging has to be reasonable. I mean, I have no issues on that. It cannot be something, which makes hospitals lose money, and that's not correct. So for that, I think there has to be negotiations, discussions between GIPSA and the hospitals, so that the rates are in line with what is reasonable. But see, one more thing we also have to keep in mind. See, if healthcare providers want to increase every year, the insurers will say, I want my premiums to increase every year. I mean, see, that's not going to happen. At least the people of the country who are the ultimate beneficiaries of either the hospitals or the insurance companies would say, I mean, don't increase my premium for 3 years. That's what the regulator also says. You don't keep on increasing premium every year. So these rates will remain constant for a certain period of time, but it has to be fixed up in such a way that it takes care of expected inflationary trends. I think that is going to be the reality. Now, in this, I only see collaboration between the hospitals and GIPSA or other insurance companies, because as Mr. John very rightly said, the other insurance companies would also like to follow GIPSA rates or even go lower than that if it is possible. And there is also a move sometime back, though it has not gained traction. The entire insurance industry wanted to negotiate rates and fix standard rates, not only GIPSA companies. So these are from the insurers side. These are some of the trends. Because see, the problem for the insurers is they are suffering losses. They want to know how can we really manage this. They're not able to increase premiums because it's becoming unaffordable. Health insurance premiums are really high in our country, and we don't want to go to a US situation where health insurance is beyond the reach of people. So they want to reduce, healthcare costs. So I think one area where, all of us will have to work together is how do we reduce healthcare costs? I mean, I think that is something we can't lose sight of. It cannot be cost plus model, because then it doesn't encourage efficiency. So I think everyone will have to see how do we reduce the cost of healthcare, because India is not a developed nation. We are still a developing nation. Many people can't afford. That's why government's Ayushman Bharat package rates are not as much as GIPSA rates. I think we cannot lose sight of the objective of how do we reduce the healthcare cost. We don't want to go the US way, at least as far as this is concerned. But in respect of the problems of the hospitals, I think negotiation with insurance industry is probably the only way forward, and that can easily happen.
Okay. And now other question which I'm seeing on the chat box is that will it happen that private insurance company will also follow the GIPSA rates? These people are asking this question.
I told you that they would like to follow GIPSA rates. They would like to better the rates, and probably the entire insurance industry would like to formulate standard rates.
Right. Now let me just go to Father Johnson. He is our stalwart in the industry. What you think on this issue? But government keeps talking to us, whenever we meet them. Government says it is time that the hospitals also learn to minimize the operational cost. Somehow they think, when we make good buildings and, good infrastructure, they think that we are earning a hell of a lot of money. While we keep telling them that this infrastructure is required in this particular way to minimize the infection and improve the patient safety. Don't look at the marble and all that. This is meant to reduce certain minimum, you understand that. Now, question is, do you think in your experience that hospitals also can work in improving the operational efficiency and thereby reducing the cost? Do you think there is a scope, and what is the way it is to be done?
First of all, let us agree what we are talking as a rate or a cost has never been so far scientifically done.
Right.
Without doing it scientifically, either telling you reduce or hike it is just a personal perception of each individual who is sitting across which side of the table. The fundamental issue is there is no scientific evidence what is cost for procedure to be done. Under this circumstance, definitely there will be a scope to improve the efficiencies, improve the things, but let us address it. Have we ever seen what is the cost of government hospital running? The government, which is supposed to be advising private how they should run, there was a study which showed government hospital is spending more money than the private to treat the thing. When that is the example that has been put in front, where the land is free, free means taxpayers' money, government equipments are given, and today Ayushman Bharat pays the same price to government entity and to a guy who has put in money and spent. With this kind of inconsistencies, in my humble opinion, there are enough people who run the hospital very cost effectively. So our illnesses are 80% are secondary care, 20% are tertiary care. Whenever we think of healthcare, we don't need to really think only tertiary care as a healthcare. These 80% can be easily looked after by the neighborhood hospitals, which are hardly utilized today. And what is happening is the cash paying patient is subsidizing the insurance or a scheme patient. Hospital has to pass on this to somebody else. So I think the answer is get a scientific study, make this acceptable to one class of people across the thing, depending on the cost.
Good, good.
Then it will be all right, sir.
So I understand. Actually, what he's saying, I actually subsidize to what he's saying, that today hospitals have started, understanding because of this competition, number one, reduced inflow of money. They have already, tried to improve the operational efficiency. Now, Joy, a small question which has come in the chat box is that when Mr. Srinivasan said that, there will have to be deduction because they will go by, the one X-ray or two X-ray, Do you think there can be a method between the insurance company and the hospital body, let us say HPI, CAHO put together, that there should be a mechanism of making this very transparent, because we keep saying that GIPSA doesn't have that kind of medical expertise. So on what basis they are reducing, but they also keep saying, so I mean, there is both ways there are confrontation. Do you find some easy mechanism can be involved by which this, pain point of deduction can be addressed?
So, Dr. Gyani, we heard the example of US insurance and all. And if we compare with Indian scenario, you need to see that like what kind of economy it is. That is like insurance companies are driving, and in India, insurance companies are yet to have that kind of control over the healthcare providers. As a result of that, in US, what happened very easily, that companies have made their own formula of pay for quality. So when you have that kind of outcome, you get the full thing. If somebody gets readmitted, you cannot charge. It has to be done within that payment. Because of that kind of, authority, it has become possible. But in India, that kind of control mechanism is not there. What you told exactly, that pay for quality, pay for outcome model, where there is a transparent way, a neutral body, as you mentioned, like HPI, CAHO, can develop that entire algorithm. When I say algorithm, I mean the kind of standard treatment guideline, protocols, and very importantly, there has to be a regulatory body which will tell that hospitals have to adopt that. Today, if I become very good, governance-wise, and I try to adopt that, I may get a question. Sometimes in my hospital, I get patients, they say, why you didn't do this MRI also? You could have done this MRI after CT, so rule out things. But if you really want to be rational and try to do the justice, you may not get accepted by the patient, but if you don't follow, you may get question from the insurance company. So it is very necessary that guideline, what we discussed, or the clinical pathways that, standard treatment guidelines are developed by a neutral body, keeping all the quality parameters and aspects into consideration. And if that gets adopted by the insurance company, probably the conflict between the hospital and insurance companies will get reduced significantly. But in absence of that, today what is happening, it is happening in an arbitrary way. Sometimes we get question from the insurance company after patient discharge, when they have committed to pay certain amount as a for the payment for the treatment, they come back and say, I'll deduct this. But on what basis, there is no idea, there is no clue. So I think it is a good idea that we come out with this kind of guidelines, and then healthcare providers can be brought under the same platform to adopt it. But if it is getting driven at this scenario when healthcare is completely, I'll say, non-regulated or not dictated by the insurance company like US and all, it becomes very difficult to manage.
I agree. I think it is very possible to come up because our associations can play a significant role, because this is a time when we work jointly together. I wanted to know from you that how hospitals can improve the operational efficiency, which of course Nagendra Swami replied to the extent, but still we want to see your views, because government keeps complaining that you are spending more money, you are expensive, so and so. Do you think there is a truth in what they are saying?
The issue is that everybody needs quality care and affordable cost. These two components are, to a great extent, it's a big challenge. So to an extent, what I try, mine is, it is, a mission hospital. Now at my level, what I try to do is to work on the numbers. But still I find it very challenging. And even if you start negotiating with the vendors, suppliers, there is a limit to everything. And I think, the costing part should be seriously considered, by the insurance companies, by the government. And I think after this discussion, Srinivasan sir would be our spokesperson, in meeting all these challenges. That's my comment.
Very nice. You see, so Srinivasan, what Father just now mentioned, and Joy also mentioned before, the quality healthcare is going to cost, because of this nowadays, this is political pressure, community pressure, medical legal cases on top of it. Hospitals are sometimes perforce, get into the defensive medicine. Bit of one extra test because of one extra so and so, because of this all pressure which has been created around that, So it is not very easy for let me tell you, for the hospital to manage in this kind of environment. So that is where, we definitely need a kind of working closely together, association of the insurance company, GIPSA, and HPI, CAHO. We can really put our best of the efforts to support GIPSA in that account. Do you think there is a kind of opportunity where we can create a framework?
See, there are two things. One is I really like the idea of Mr. Joy. He said, could there be an independent regulator for hospitals? And then the regulator can say, what is the line of treatment? What is the cost? I think everyone will agree. There will be no dispute. Probably, all the stakeholders can always put up their points of view to the regulator. So this has been one of the suggestions of the insurance industry for many years. I don't know how the healthcare providers feel about it. Because the insurance industry is now trying to regulate because there's no regulator. So which is where the problem is. So if there is an independent regulator, where all the stakeholders could be involved in them, and they come out with what could be the cost, what could be the pricing mechanism, and what is the line of treatment. I think then everyone will accept without any question. I think that's a good idea if it's possible. The other one, if it does not happen in the short run, at least I would now move ahead of GIPSA, because there is General Insurance Council, which is a body of all insurers. Probably the hospital organizations need to interact with the General Insurance Council and really, thrash out these issues. There are issues on both sides. I mean, if you ask the insurers, they will talk about 10, 15 issues. You talk to the hospitals, they talk about 10, 15 issues. I think these issues need to be discussed and a way out can be found out. I think I would suggest on the insurance side, General Insurance Council, which really represents the whole insurance industry, could be the right body for the hospital organizations to interact and find solutions.
Okay, actually during COVID time, we did have good interaction with the GIC. And I think as per you are advising, we will reinitiate this dialogue.
Correct.
And I think you can be our, helpful in that context. CAHO and HPI will work together with the GIC. And I think you will be our partner, as Father Johnson also mentioned. Let me go across. There are a few minutes left to Dr. Vijay, because he has been, because in fact, I put a small article in the Money Control that there should be an independent regulator for the hospitals. It got few reaction from here and there. Some people were saying, why bring an additional regulator? I told them that you are already under regulation by government, so better to have an independent regulator. Dr. Vijay, your closing remarks.
Thank you, sir. It has been a very nice discussion and has opened up a lot of naturally pain points and possible solutions. My feeling is that number one, that insurance companies can play a huge role in promoting quality, and how they can play is I have some ideas. So, for example, at the moment, that every hospital which has, for example, NABH accreditation, whether the hospital is in a tier 3 town or tier 1 town, whosoever, which has a stamp, there is a standard kind of a thing. I think we need to today probably make a differentiation that it may start with somebody getting a 2% increase to 5% increase to 7%, 8%, 10%, 15%, 20, 25, that kind of slabs. So for example, a hospital which has adopted EMR, if you have adopted the entire digital system in terms of admission, discharge, your clinical thing, should be compensated in a little better way by the insurance companies. The insurance companies must share the outcome data. You see, for example, every hospital's outcome data in a very nice manner is available with the insurance companies. If I ask the hospital directly, people may not believe it, in the sense that whether it is true, it is not true. So some kind of a bracketing can be done as to bracketing the same kind of complexity. What was the outcome? What is the kind of a outcome for a CABG, for a plasty, for a knee replacement? You lay down whatever parameters, and on that basis, the insurance company should publish that data in public domain. Today, that is very much possible in United States. I don't see why should it not start to happen. And similarly, there could be other objective parameters in a hospital to showcase that whether what kind of a quality infrastructure, what kind of a quality they have institutionalized. So according to them, first of all, the money that is available to them as an incentive should be based on those parameters. And so that is one thing. And second, of course, following standard treatment guidelines, having a neutral kind of a thing will be very welcome by the healthcare industry. I am not sure whether it will be welcomed by the insurance companies, because eventually it all will come down to one problem, that today we are trying to treat patients at a cost which is much lower than what the hospitals are incurring. And therefore, the money is being paid by the cash-paying patient. I feel sometimes probably a cash-paying patient has to probably file a court case or something. That is the major problem. So a very nice study on costing and pricing, some of them have been done, but more can be done. And this should come in public domain. But my at least thought that I was trying to say is that today we are wanting to promote digital adoption. We know that digital adoption removes a lot of problems. Hospitals have to also do an introspection to see how do we make ourselves more affordable rather than making ourselves more expensive. Yeah. So we can, and therefore some of the hospitals which may be charging the people for the granite and for the nice, the hotel part of the hospital, the patients can be given that in these hospitals, you have to pay this much amount of money extra.
Yeah, but I think we all had a very meaningful time. Thank you, Srinivasan, sir. So I think we need officially a vote of thanks. So Ms. Gayatri Sandeep, please come with your vote of thanks.
Thank you, Father Johnson. It's my privilege on behalf of CAHO to thank our panelists, Mr. G. Srinivasan, the Director, National Insurance Academy, Pune, for sharing his views and domain expertise in this panel, and Mr. Joy Chakrabarti, CEO of Hinduja Hospital, Mumbai, for a lively discussion and sharing all the pain points of the hospitals in this panel again. And of course, Mr. John Vincent, CFO of Rajagiri Hospital, for sharing his valuable experience in the finance sector and the finance concerns of the hospitals in this forum. And of course, our ever youthful, energetic leader of the masses, Dr. Gyani, for moderating this beautiful session, making it very, very special to all of us. Thank you, Father Johnson and Dr. Vijay Agarwal, for giving me this opportunity to convey the vote of thanks, and each and every one of you in the audience for making this program so successful. And of course, it is the need of the hour to make the insurance sector as well as the hospital both profitable and meaningful to the patients. So I thank you all for joining this session, for making it really, really worthwhile and more productive for CAHO. Thank you very much.